Thank you, Mr. Chairman, and thank you for inviting me today to talk to you about second-line treatment of metastatic renal cell carcinoma and new making strategies. It was a difficult task. So my approach in doing this was looking at the evidence, going through subgroups for better selection of patients. Dr. Andrew just saved me from my first few slides about introduction, just to say that number of patients, like any other cancer, number of patients treated decreases with each subsequent line by almost like 50%. So it's important to maximize the efficacy on each line of treatment. These are the trials that I'll be reviewing with you, not in deep. I will just go for the points that help us in building the strategy and selecting patients. I don't see it very well, but here's the everolimus, axitinib, nivolumab, lenvatinib, everolimus combination, and cabozantinib. And this is just a summary of the trials. I will go one by one. So you heard about these things from Dr. Andrew. So ideal second line. Here's the NCCN guidelines for the subsequent or second line therapy. Pretty much includes everything: cabozantinib, nivo, axitinib, the combination lenva, and others. When it comes to the European, I'm not sure if you can see this, but yeah, maybe this is the one. The European urology surprisingly included in the first line Dr. Andrew ipilimumab, nivolumab, although I'm not sure it's approved yet. But just to pay some attention to the red boxes. So again, we classify patients, good risk group, intermediate and poor risk group. If they receive sunitinib or pazopanib, then it's recommended to have cabozantinib or nivolumab. If they receive immunotherapy first line, then it's VEGF targeted therapy. And the same thing applies for the second line. So starting with AXIS trial, which led to the approval of axitinib. This study looked at axitinib versus sorafenib in a second-line treatment. Compare the trial. So this is phase 3 trial. Primary endpoint was PFS, and the comparator arm is sorafenib. The study met its point, its primary endpoint. Also the checkmate trial, which looked at nivolumab. The comparator was everolimus. It's again phase 3 trial, and the primary endpoint here is overall survival. Then the METEOR study, which looked at cabozantinib, it's again phase 3 trial, compared cabozantinib to everolimus, and the primary endpoint was progression-free survival. Then we had the HOPE trial, which looked at the combination of lenvatinib and everolimus. This now is a phase 2 trial, so you can take it in this context, and the primary endpoint is a PFS, progression-free survival. And lastly, in my presentation, but it was the first to be approved in second line, is the RECORD-1. It's a phase 3 trial looking at everolimus compared to placebo, and the primary endpoint here was progression-free survival. So to me, when I have a patient in the clinic, I will look at these things, and that's how I designed my presentation. I will look at the study design and the quality of evidence, risk groups of the patients, tumor burden, impact of prior therapy, safety, age, and comorbidities as patient factors. I will start with you with the study design, and here's summarizing the study design. Probably we mentioned most of these things. So all of them are phase 3 trial except the HOPE trial, the lenvatinib everolimus combination. The comparator arm was placebo in the everolimus, sorafenib in the axitinib trial, and the rest of them were compared to everolimus, which was the standard of care second line at that time. So what about risk groups, and does it matter really when we come to select our second line treatment? So start with the axitinib, which was compared to sorafenib. And axitinib showed a significant progression-free survival benefit in favorable and poor risk patients. As you can see from this study, they're all significant. Also, it showed overall survival benefit in the favorable risk group patients only, as you can see here. Significant p-value, but it was not significant here. Okay, so when it comes to nivolumab, when it was compared to everolimus in the Checkmate 025 study, nivolumab showed overall survival benefit in the poor risk group, as you can see from the nice separation of the curves here, which you don't see in the intermediate and favorable risk group. So it would be a preferred option for the poor risk groups. Cabozantinib, on the other hand, showed a significant clinical benefit in favorable and intermediate risk patients, but not the poor risk group. Overall survival benefit was shown again in the favorable and intermediate risk groups, as you can see from the separation of the curves, but not in the favorable risk. I will summarize these things later. So then we had the lenvatinib everolimus combination, and that showed a progression-free survival benefit in favorable and intermediate risk group. As you can see here, the first two, p-value was significant, but not with the poor risk group. That was insignificant. So in summary, axitinib is showed the benefit in the favorable risk group. Cabozantinib benefit was mostly in the favorable intermediate risk group. Nivolumab was mainly in the poor risk group, and for the combination lenvatinib everolimus, it showed its benefit in the favorable intermediate risk group. And I would enforce the point that this is all subgroup analysis. You will see some retrospective data, but that's my own biased way of looking at the evidence and building strategy. We know tumor burden is an independent prognostic factor in metastatic renal cell cancer and is directly related to progression-free survival. From this point, when we look at the axitinib in the AXIS trial, axitinib showed significant overall survival benefit in lower tumor burden compared with patients with higher tumor burden. So the lower tumor burden, they benefit more from axitinib. When we look at the nivolumab in the Checkmate trial, it had overall survival benefit in patients with multiple metastatic sites, as we can see from this curve. So 2 or more metastatic sites. Sites of metastasis, if it's bone or liver, there was a trend towards overall survival or better overall survival benefit of nivolumab in patients with bone or liver metastasis. When it comes to cabozantinib, it had an overall survival benefit in patients with higher tumor burden at this point, as you can see from the wider separation of the curves in patients with higher tumor burden. Also, overall survival benefit was actually here is irrespective of the tumor burden, and you can see for regarding bone metastasis, visceral metastasis, or both bone and metastasis, they all benefit regarding overall survival from cabozantinib. Regarding lenvatinib everolimus combination, the progression-free survival benefit was irrespective as well, irrespective of the tumor burden or size of metastasis. As you can see, they all like the p-value maintained its significance no matter what you look at, site of metastasis or the tumor burden. So in summary, axitinib is regarding tumor burden showed preferred activity against lower tumor burden. Cabozantinib works better in higher tumor burden, if you will. And nivolumab, there's some evidence that multiple metastatic tumor sites benefit more from nivolumab. And when it comes to lenvatinib everolimus combination, the benefit was irrespective of tumor burden. So what about the impact of prior therapy? Starting again with axitinib, there was a trend towards longer overall survival benefit in patients who are treated with sunitinib more than 1 year, as you can see in this curve. So median overall survival was 11.7 months in those like short duration of sunitinib treatment and 18.1 months in those with longer sunitinib treatment. Regarding nivolumab, overall survival benefit was irrespective of the duration of the first-line treatment. So there was no difference between the two, either less than 6 months or more than 6 months in this study. For the cabozantinib, the benefit was again irrespective of the duration of the VEGF treatment. As you can see here, less than 6 months or more than 6 months, they both derived the same benefit. Also in everolimus, the clinical benefit in patients who had received 1 or 2 previous VEGFR TKIs was as proven in the study, and there was no difference. As you can see, p-value was significant in both, either they received 1 or 2 lines. So what about safety? Safety is a major issue, especially with those new agents that we are now getting experience more and more with. And I'm summarizing the most important safety data in this slide. So axitinib, grade 3, 4, I don't know if you can see, but the grade 3, 4 adverse events is 66%. Most common adverse events were hypertension, diarrhea, and fatigue. For the nivolumab, they reported the treatment-related side effects, which was 19%. If you read through the trial, all side effects are more than this, yet not to the extent of the anti-VEGF, like 66%, much lower than this. Regarding cabozantinib, even its higher rate, 68%, grade 3 and 4. And yet it maintained a good, fairly good quality of life compared to everolimus. Lenvatinib everolimus combination reported the highest rate of grade 3 adverse events, 72%. And the everolimus, patients who have received everolimus had higher rates of grade 3 for stomatitis, infection, and pneumonitis. So what about other factors? Route of administration, age, comorbidities. So all of these agents are orally administered with the exception of nivolumab, which is intravenously. Regarding the incidence of side effects in elderlies, we have an evidence that cabozantinib was associated with higher rates of adverse events in those who are older than 75 years. And regarding axitinib, there was no major difference in safety or efficacy observed in non-elderly patients or those who are more than 65 years. So cabozantinib is not a preferred drug according to this. For elderly, axitinib should be fine. So this is a retrospective study of axitinib in elderly patients, and you can see the benefit. The overall survival is similar in both younger and older patients. And also advanced age, of course, should not be a contraindication to axitinib treatment according to this trial. There was no difference in adverse events regarding age. For the cabozantinib, cabozantinib improved PFS actually compared to everolimus in patients irrespective of age, as you can see from these subgroup analysis, younger than 65 up to 74 and then 75 or more. They all maintain clinical benefit. As well, that was progression-free survival, and overall survival benefit was consistent with the previous results. But higher rates of adverse events were reported in each age group, as you can see here. So, yeah, so this one, where is that? Yep, so 68, 75, 70. Treatment discontinuation or dose reduction due to adverse events were more common in older patients than younger patients treated with cabozantinib. So that's another factor that proves that cabozantinib is not good for elderly patients, according to this subgroup analysis. So regarding comorbidities, we know we're starting to use immunotherapy now, and we know it's contraindicated in patients with autoimmune disease. Cabozantinib, lenvatinib should be used with caution in patients with hypertension, congestive heart failure, and cerebrovascular events. Of course, everolimus also cause hyperglycemia and should be used with caution in diabetic patients. So in this slide, I'm trying to lump up everything and summarize things. So we know, again, they're all phase 3 trial except for the HOPE trial. The better number of patients, the highest number of patients were in the CheckMate trial. For the discontinuation because of side effects, axitinib was the best, but also it's really not different from CheckMate and Meteor study. Hazard ratio for PFS was more impressive in the AXIS and Meteor study. Overall survival hazard ratio was better in CheckMate and the Meteor study. Overall response rate was highest. You don't see because I'm hiding that. I don't know if you can see it, but it's 43%, which is the best response rate reported in second-line setting. Remember that also it had the highest reported rate of grade 3-4 side effects, 72%. It's not really that higher than cabozantinib or axitinib, which is again in the 60s. So in my conclusion, axitinib is good for elderly patients, favorable risk group, maybe lower tumor burden after first-line treatment with 12 months or more. Be aware that the grade 3-4 side effects, 66%. Discontinuation rate is not high, 7% because of side effects. Response rate 19%, and the study primary endpoint was progression-free survival. Regarding nivolumab, it's worked better in poor risk group, multiple metastatic sites, irrespective of line, so it works in second line or third line treatment. And now we have a new data when it's combined to even in the first line. Grade 3-4 side effects is less than those reported with the anti-VEGF. And the trial endpoint was overall survival, which was met. When it comes to cabozantinib, it works better with favorable and intermediate risk group, higher tumor burden this time, irrespective of line of treatment, and it induces more side effects in elderly patients. The lenvatinib everolimus combination works better in favorable intermediate group, irrespective tumor burden, relatively high grade 3-4 side effects. Discontinuation rate was 29%, but a very good response rate at 43%. And with this, I'd like to thank you.